peptide increases. The next paper will be presented by Dr. Martin from the Central Carolina Surgery, and it's titled Laparoscopic Adjustable Gastric Band with Truncal Vagotomy, Any Increased Weight Loss. Dr. Martin?
Thank you, and thanks to SAGES for allowing us to present our data. I'm presenting this on behalf of one of my partners, Dr. Earl, who couldn't attend the meeting, and also on behalf of my other two partners, Dr. Ben Hawksworth and Dr. David Newman.
The green button to go forward.
We have personally nothing to declare, although Central Carolina Surgery did receive partial funding for this project from Endovix Incorporated, unfortunately now defunct. Central Carolina Surgery is located in Greensboro, North Carolina, sort of the heart of North Carolina. There are 18 of us that practice general surgery. 4 of us have been doing laparoscopic bariatric surgery since 2003. We're COE designated by the ACS in 2009, and we worked together on these, and we contributed to this study. The objectives of the study were to look to see if the addition of truncal vagotomy to LAGB would augment weight loss, and is there any combined, is a combined treatment safe? Gastric restrictive procedures in the 70s and 80s were oftentimes sabotaged by excessive hunger and patients that would develop maladaptive eating disorders, and it were driven to regain their weight. Dr. John Krall and his associates were the first to combine a truncal vagotomy with a vertical banded gastroplasty and compare that with vertical banded gastroplasty alone, and they showed a statistically significant weight loss compared to VBG alone. So the question is, could that apply to the laparoscopic adjustable gastric band patients? The conventional wisdom in surgery was that if you did a truncal vagotomy, you'd need to do some form of a drainage procedure, pyloroplasty or a gastrojejunostomy, and that's what I was taught. But also at this meeting and others, people talk about inadvertent vagotomy and how is oftentimes blamed when you're doing foregut surgery that the patient is having diarrhea and bloating, and it's often maligned. But going back and looking at Dr. Dregsted's paper back in the early 50s, they had 234 patients, and this was in an era of a chronic peptic ulcer disease, who had undergone truncal vagotomy alone, and only 6% of those patients required some form of a drainage procedure. So I think we could go ahead and do this safely, and perhaps rethinking the diarrhea and dumping was perhaps more related to the pyloroplasty and the gastrojejunostomies, and not the vagotomy. So the vagus nerves, most of the vagus nerve is about 80% sensory, and motor signals, they too regulate satiety and hunger, and it had the potential possibly to reduce hunger for these patients. Our methods, this was an open label, single center feasibility research trial, IRB approved. We accrued actually 49 patients, and the enrollment period began in 2006. Primary efficacy variable was percent excess weight loss, and our safety variable looking at adverse events. We got an observational matched cohort of 49 LAGB only patients selected by an independent reviewer, looking at correlating with age, sex, BMI, and ethnicity. The technique involved exposing the anterior and posterior vagus nerves, clipping and dividing them, removing them for subsequent pathologic examination. We did an on-the-table endoscopy with Congo red testing after irrigating the stomach, and also giving intravenous baclofen. And then went ahead and implanted a 10-centimeter Allergan lap band by the standard pars flaccida technique. Our results we have for 41 of the 49 patients greater than a year and a half out, an average post-op of about between 33 and 36 months. The percent excess weight loss was 38% in the LAGB and vagotomy, and 36% in the LAGB alone. There were no adverse events, no reports of dumping or diarrhea. One patient with mild delayed gastric emptying. There was an excellent safety profile for the operation, no reoperations, no mortalities. And all the patients was striking except one reported anorexia. So in summary, at 3 years, LAGB with vagotomy and LAGB alone produced similar percent excess weight loss. There's no statistical difference in what what we showed. Truncal vagotomy has not produced diarrhea or dumping in these patients. The truncal vagotomy has produced an absence of hunger in all but one patient. But this absence of hunger is not translated into extra weight loss on these patients. And finally, and if in reaching the green zone after an LAGB requires an intact vagal nerve, then one would think that the LAGB patients with vagotomies should have much less weight loss. Therefore, it's likely that the LAGB satiety is probably not related to probably related to factors other than afferent vagal nerve feedback. Thank you.
Thank you very much.